attendees are very few. Why?
I think they are joining maybe slowly. Because registration number is very much and
So shall we start now? Because we are
yes, ma'am. Yes, ma'am. We can start.
another meeting also.
Yes.
Okay.
Yes.
Yes. Okay. So starting. So, respected Professor Ghosh and our distinguished speakers, Dr. Garima Agrawal, and dear participant, I, Shreyas Dwivedi, Junior Consultant in Resilient Infrastructure Division, National Institute of Disaster Management, Ministry of Home Affairs, Government of India, welcomes you all in today's webinar on health infrastructure during emergencies. This webinar is being organized by the National Institute of Disaster Management, Ministry of Home Affairs, Government of India. So, first of all, I would like to express my sincere gratitude to our Executive Director, Sri Rajendra Ratnu sir, for allowing us to conduct this webinar, and to Professor Ghosh for their invaluable guidance and support throughout the program. So, about today's topic, we can I want to give a brief idea that health infrastructure refers to the preparedness, response, and recovery actions taken to ensure the community continuity of healthcare services during disaster and emergencies. It involves the implementation of robust and flexible plans that address the unique challenges posed by different types of disasters such as natural disasters, pandemic, and act of terrorism. So, in today's webinar, to set the context and for introduction, I would like to call Dr. Garima Agrawal, Senior Consultant in Resilient Infrastructure Division. Over to you, ma'am.
Thank you, Shreyas. And my warm welcome to all of you on behalf of National Institute of Disaster Management, Ministry of Home Affairs, Government of India. It is indeed my pleasure to convene today's webinar on health infrastructure during emergencies. My pleasure to welcome Mr. Pranav Sethi, DRR Specialist, Geohazard Society, and Dr. Nidhi Yadav, Associate Professor from International Institute of Health Management Research. I am sure their experiences and knowledge will make the program more meaningful and important to us. Professor Chandan Ghosh, who has been a guiding source behind all the initiatives and have immense expertise on this subject. My warm welcome to you, sir. I welcome all the participants wholeheartedly for taking out their time for this webinar on an important theme. You all may be aware that an NIDM has been established as an apex body of Government of India for capacity building in the various areas of disaster risk mitigation under the Disaster Management Act 2005. A national level capacity institute, it is mandated actually to hold training programs and research programs with the state governments, organization and other important stakeholders on regular basis. And this webinar is also one of the initiative towards continuing our mandate in the field of DM. Health infrastructure, be it hospital, clinics, public health centers, pathology labs, or pharma chains, they play an important role in providing the population with complete healthcare system. It houses a wide range of emergency services, diagnostic treatments, laboratories, housekeeping, and storage of flammable treatment materials. Apart from that, it has most vulnerable segment of the population, like diseased and disabled pregnant women, children, and infants who cannot move without support if there is any emergency, and they are needed to be moved with a lot of care. During any disaster like earthquake, which can cause serious damage to the structure of hospital buildings and health facilities in various parts of the India, where seismic risk is very high, the main reason of failure of the healthcare facilities during emergencies is mainly due to the structural and non-structural damage, which poses a risk to the healthcare workers and patients as well. During pandemic, we all have observed that how hospital systems is suppressed due to limited resources and huge demand of patients. So it is important to strengthen and secure the existing resources as well as the future resources. I would like to quote few examples from the previous disasters like Gujarat earthquake, where the main 250-bedded civil hospital was collapsed and killed about 150 patients. Apart from that, the civil hospitals and other health facilities in Kutch were completely destroyed. As a result, a huge influx of patients was sent to various parts of the state which were located over 60 kilometers. As the present system, the existing system in that particular area was crumbled. Similar situations were seen during the pandemic also. Several hospitals caught fire, like Ahmedabad Civil Hospital in November 2021 is one example where 14 deaths happened due to fire, and it was huge mess in the hospital, and the staff also went on protesting, saying that why we were not following the fire safety norms, why our sprinklers our fire suppression system was not working or it was not installed. So similarly, if you remember Jammu and Kashmir floods in 2014, the civil hospital in Srinagar was underwater for around 2 weeks, and they could not perform their function for that period. So the point is that we have safety standards under BIS, but somehow when it comes to the ground level implementation, things are missing. Apart from that, if the supply chain for the health facilities is often disrupted, and coordination and communication between disaster management organizations and health facilities such as hospitals, big hospitals, is another important area in emergency situation. So there could be an outbreak of secondary diseases also if situation is not under control. So there is a huge need to build a safe health infrastructure which do not collapse in disasters, do not kill people, and can continue to function and provide services to the community when we need them. They need it the most. So this is the only possible when we build strong structure, having a good design, and follow non-structural measures and functional measures, which which also has a robust hospital disaster management plan. So Government of India has taken several steps to strengthen the institutional mechanism of the country to handle disasters. National Disaster Management Authority, which has been constituted under Disaster Management Act 2005, have developed various guidelines to handle the disasters, and especially for hospitals, they have a National Hospital Safety Policy Guidelines, which they had published in 2016. And I think Geohazard Society had worked in these guidelines. So, and the vision of those guidelines is basically to have all the hospitals in India which will be structurally safe and functionally safer for the disasters, and the risks for the human life and infrastructure can be minimized. So towards the end, I would like to say the health infrastructure is very crucial during emergencies as it provides essential medical care to those who need it. A well-prepared health infrastructure is necessary to ensure safety and well-being of the healthcare workers and patients. The proposed webinar will provide this opportunity to discuss those issues which I have highlighted right now, and to think about how we can increase the resilience of hospital buildings and other health facilities. So the discussion points could be to understand the gaps in safety measures for protecting the hospital buildings, and to address structural and non-structural measures of safe hospital buildings, and to discuss hospital DM plans. So once again, I request all of you to take advantage of today's deliberation, and I welcome all resource persons for this on this occasion, and I wish that the participants may actively get involved into discussions and share their knowledge, examples, and also share their concerns on the topic. Thank you very much. Over to you, Shreyas.
Thank you so much, ma'am, for giving a very insightful idea about today's webinar. And now I would request Professor Ghosh to share his thoughts about today's webinar and show us some idea about what we are going to discuss today.
Thank you, Sesh, for taking up this online program. Though pandemic is over, but we are still finding a lot of opportunity, calling experts from International Institute of health management, no?
Yes, sir.
Emergency health management, Nidhi, Dr. Nidhi, and also Pranav, yes, from Jehojar Society, who has grown in front of my eyes. Of course, not the eyes, but the mind, as well as that how we are seeing you growing up for more than 10 years with your association and with your services to the mankind. So that way, this 1.5 an hour maybe interaction would be good enough to take the bites. And I have nothing much to say, but when we talk about the health emergencies in hospital and being from resilient infrastructure division in an NIDM, I just cannot keep up my temptation showing you something. No, in rather saying is not enough, but showing something. I would like to share a video that how health emergencies or a hospital, base isolated hospital. There are few hospital being made recently. In fact, yesterday I was attending 3 days India construction meet at ICAR auditorium. And there are CPWD and PWD and many construction agencies across the country, and also from Korea, Japan, they participated. And there are some award ceremony also. So CPWD has made one hospital recently completed using base isolation device in Dwarka, and also PWD, Public Works Department. They have made also 500 bedded hospital in GTB hospital at Shadra. So I would say that there are 2 more hospital being made recently with this with the technology that which can save the building from shaking or vibration. So the health emergencies and other things that what we understand is that now hospitals are being taken up, even though they are costly in the beginning phase. But when we talk about the health emergency, it is very much important to keep with the health of the health provider, and health who are providing the health. It is the doctors and facilities that are available in the hospital. So it is first step would be to make the hospital safe, or and for that matter, what are the devices from the structural or resilience point of view to be arranged. The structural arrangement that has to be made is that keep off the vibration of earthquake, especially reaching to the operation tables or in the hospital. So that in fact gives us a step forward to take or to safeguard hospital facility from such kind of vibrations that or earthquake waves that which we are facing even in Delhi, or for that matter, it is being encouraged to have such kind of hospital, structure which will be safe, or at least vibration will not be affecting the functionality of that. So, and for that, I just want to show a glimpse of a video that where hospital beds are being shaken. It may be 1 minute video I would like to share that this one, just see that, just only it will take 2 minutes. I will show only short snap of hospital.
Yes, sir.
That of course, this is the hospital that being made, and also this one. This is that hospital being made. CPWD government. This is in Karnataka, but in CPWD and Sector 6, Government of Karnataka staff colony in Dwarka 6. But this is some hospital being made, 8-story, and also I would like to show that even 500 bedded new ward block, 8-story RCC frame structure building at Guru Tegh Bahadur Hospital campus. Now this is being made, devices are available, we have placed them. But where is the scope for checking that whether hospital will behave really during shaking, all right or not. See that this video. See this video. Just I'm taking it to a hospital test.
Impact on hospitals.
Yeah.
Structural damage, like collapsed ceilings, broken sprinkler piping, damage generators, broken air handling units, damage to hospital equipment that forced many of them out of operation just when they were needed most.
They were doing triage of the parts.
So I'm going a little faster.
And the California scientists
And then how such things which has happened is being tested and experimented and then brought to the profession. Like we are employing base isolators, but before that we have to see that how they perform. So this part you see, this is a hospital which is being shaken. Now everything is made, 8-story building. It is all system is there. And these are all real thing is there. Of course, patients are also dummy patients. Of course, we cannot just do this experiment with a live person, but see that everything is in place in a hospital system that which you see. And it is an 8-story building, made all the materials available. Even fire test has been done. Hospital also arrangement that you have seen just now, it is being done. And all those arrangement for maintaining its integrity is also made. And then all measurements, they are in place. So it is an experiment. She is the project director and taking all feet, all camera, everything. University has done this test, and with all stakeholders here, you see the measurement devices and all the kind of sensors that they have placed in the entire building, and which unfortunately has not taken any place in our way of construction, because some others have tested, so we are buying it and we are placing it. That is also more enough. We don't have to repeat that. But what is to be taken, that you see that how hospital is being shaken, how all these lines, all these cables, taking measures of each and every movement of the items that which are being shaken, and taking all cognizance, taking all measures here with videography and sensor, and showing that how they are being performing, and which, of course, all these things, when this is happening, this is a simulation of the things that which happen really. Then later on, they have made, when hospital shakes this manner, cracks occurs, but they have not pull-ups. You see that what has happened over there. Then later on, just I go little forward, they checked, they get the guarantee that lift, doors, everything will be operational. There will be minor damages will be there. Some protections are taken so the non-structural element doesn't fall down. Then after that, they have put some heavy, again you see, it is being tested on a large earthquake, which happens maybe in 500 years once. And same hospital, they have rearranged it. Now you see there is a more devastating impact is there. So these are being studied, and then only we can give a real certification to the performance of the hospital. Otherwise, telling, talking, discussing will aware us, but when it is in terms of hospital, we have to safeguard the hospital. Now, do you see that with such kind of shaking, patients or any facilities can survive or not? But what from civil engineering side stuff is that building is not going to collapse. It is only that other element, non-structural parts, machinery, they are being broken or out of service. So for that to maintain, so what kind of devices that they have made to make the hospital, so these are the base isolator, which I'm talking about, our PWD or CWD has given. So with this base isolator, now when it is shaken, there is hardly any impact onto the facility. And you see that shaking is going on, but this is very mild shaking is there because base isolator is provided. So the point of discussion is that you see that it is shaken with the same earthquake, but no impact is there. You see the right side and left side. What is the difference between with isolator, without isolator? I think this much that just I wanted to show, I think to start with. So thank you.
Thank you so much, sir, for sharing this new innovations and more about
Okay. So I think just
practical knowledge, which we should practice than theoretical. So thank you so much, sir, for your insightful views. And participants, after this, we are going to start our today's two technical sessions. And before starting that, I will give you a brief idea what we are going to do today. So the first session will be conducted by Mr. Pranav Sethi. He is a DRR specialist from Geoscience Society, and he will talk about the importance of infrastructural risk mitigation and fire safety measures. And the second session will be conducted by Dr. Nidhi Yadav. She is Associate Professor at the International Institute of Health Management Research, New Delhi, and she will share insights on disaster management plans for hospitals. So we will start our first session today. For that, I would like to call Mr. Pranav Sethi, and I would like to give a brief introduction about him. He is a postgraduate in disaster management from TIS, and he has been associated with Geohazard Society over 8 years, and he is working with Geohazard on various projects related to the WHO, World Bank, UNDP, and Habitat, which is related to the field of disaster preparedness and risk mitigation for health facilities in not only in the India, also in the Nepal, Bhutan, and Myanmar and Maldives. So over to you, sir. You can share a presentation.
Thank you, everyone. Thank you, Dr. Ghosh, Dr. Zarima, Shreyash. I'd just like to start with the fact that I used to be a student of Dr. Ghosh. I started as an intern under him, and I'm really happy to be on this platform and sharing a presentation with you, sir. I'll quickly start. Shreyash, just let me know when I'm supposed to finish. Okay?
Okay, fine.
Yeah. So we will be, let me just fix the screen just a second. Yeah. So we will be discussing about infrastructure risk mitigation and fire safety. And thank you, Shreyash, for the quick introduction. I'll just quickly start with just talk about my organization. I'm working for Geotag Society, and we are working with the most vulnerable communities in South Asia. And when we are talking about vulnerable communities, we are talking about people who cannot defend themselves, people who need additional support. And this can be school students and this can be hospitals, both. So I'll quickly go towards fires in health facility. Garima ma'am mentioned about a couple of incidents, especially during COVID. A lot of fire incidents have started to happen, and on a monthly basis, I guess if you are going through the newspaper on a monthly basis, at least a paragraph of a small fire incident in one or the other hospital, either in India or somewhere abroad, you could see. So this is a picture of a hospital fire that happened during COVID in Iran. And as you can see in the second picture, like the entire building got burnt and a lot of patients had to lose their life. So fires are, uh, you know, hospital fires are pretty common. We cannot close our eyes, shut our eyes towards it. And that is a fact that we need to accept that fires can happen in hospitals and especially in our hospital. I'll quickly just mention one more thing. During my field experience over the last almost a decade now, what I have learned is that many facilities across the world, they believe that they are safe, and what they have to prepare is for people who are going to come in case of a disaster, like there's a mass casualty event and people who are going to come to seek help, but they forget that they are also vulnerable. Their families, they themselves are also vulnerable, and that is a very important point they are missing. So this is extremely important for health facilities and for all the people out there today who are listening to me. That what we are going to discuss today is not just for your for your health facilities, but also for you. So take it back home, discuss it with your family, and go back to your offices and your workplace and discuss with your colleagues also. So some important facts about fire. When there is smoke, there must be some fire. Smoke doesn't come out without fire. So that is the first sign. The moment you see smoke, there is a fire and a small fire. If you detect a small fire, it could be easily controlled within the first few seconds. I'm talking about seconds over here. I'm not mentioning about minutes, because a small fire can turn into a big major fire within 2 minutes. So if you see a fire, you just have few seconds of window where you can control it. But to control it, you need to know how you can do that. And a majority of people in hospitals, especially like sir was mentioning, ma'am was also mentioning, that hospitals are places where people who are incapable of moving on their own, especially the sick people, people who are bedbound, they need support, and that's what makes them more vulnerable. So we need to make sure that our hospitals are safe from fire incidents. So all of you must have seen fire extinguisher, fire hose pipe, but having them themselves are not sufficient. You need to be trained to use them. I've seen people who I've seen hospitals with the best of the technology, best of the fire safety equipment, but the staff is not aware how to use them. And believe me, that is where they lose. If the staff is not aware on how to use these function extinguishers and firefighting equipment, chances are if there is a fire, they will not be able to perform, and the fire will spread, causing more damage. Uh, Another important thing that Dr. Nidhi will discuss later is about preparedness plans. And having a preparedness plan is not enough. I get a call almost on a weekly basis that if you can prepare a plan for us. And I said, yes, we can. But what I prepare is not sufficient for you. You need to understand about your facility, and you understand that much better than me. So you prepare your plan and practice those plans. It is just like an exam. You cannot go and sit in an exam without preparing for it, right? So similarly for your plans, you prepare your plan and you practice them in the form of drills. If you cannot perform a drill, at least try a tabletop exercise. That is a simpler form of a drill where actual patients are or actual people are not brought in. It is just discussed among the hospital staff members while sitting in a single room, and a realistic scenario is presented. So that is what you can do. I'll quickly show you a video of a fire incident in Sayaji Hospital, just to give you an idea how fire can start. I'll start along with this video. I hope you all of you can see the video. So in this video, you can see there are two medical staff members who are trying to plug in electrical equipment, and they are finding it difficult to plug it in, and they have to really stretch themselves out, and the wire is also stretched, and then finally they they push the plug in and they switch it on. And this is during COVID. You can see all the patients are oxygen provided with oxygen, and are in a position which they will probably need assistance. Now the medical staff is trying to work on the particular machine over there, and they notice something's happening, something is wrong, and then they start panicking. They move out. They try to they they try to remove the patient. They try to switch off the electrical supplies, but they forget which electrical plug was used to switch on that particular equipment. And then suddenly there is a short circuit and a fire start. And you can see the patient who was already bedbound, he's struggling to move, and he needs support. Similarly, there are patients on the other side, and they are not even able to move on their own. And now we have smoke, we have fire, we have smoke, and it is spreading fast. I told you, it is a matter of seconds. A fire can turn into a big fire a small spark can turn into a big fire within a matter of seconds. So what you need to do is within those few seconds. If you watch on the left, someone will try to douse this fire using a extinguisher. And now the room is starting to get filled with smoke. We still have patients on the bed and they are not able to move on their own. The moment they apply a fire extinguisher, the fire starts, they start to put out the fire, and now the entire room is filled with smoke and the dry powder that was used to put out the fire. And the hospital staff has to come back again and again for each and individual patient. You keep watching. Towards the bottom, we have two hospital staff asking the last patient, and they are trying to drag the patient out. But the patient is hooked to an IV, and that is why that is taking so much of time. So the idea behind this video was just to show you how bad a fire can be and how fast it can spread. So to prepare for such kind of incidents, it is extremely important that the hospitals start preparing for it. You may have the best of the best facilities for fighting fires, but if you have not practiced it, it is not going to help. You need to know how to operate your fire extinguishers. You need to learn how to operate hose pipes and whether the hose pipes are functional, whether the extinguishers are functional. All of that must be checked and tested on a regular basis. I remember in one of my sessions, we were trying to demonstrate how to use an extinguisher, and we tried a CO2 extinguisher, and someone operated it. And because it is filled with gas, it comes out with a lot of noise. And the person who was using it, that lady got so scared, she just dropped the hose and ran away. So unless and until you practice, unless until you hold that extinguisher in your hand, you won't even know how heavy it is and how you can actually use it. So start practicing, start making it part of your plan that everyone in the hospital has to practice how to operate an extinguisher and how to operate fire hoses. Another important thing over here is having a preparedness plan. Ma'am will be discussing it more during her session, but I just want to quickly talk about having an evacuation plan. And the evacuation plan has to be for each and every floor, each and every floor. Like, in India we have hospitals with multiple buildings. Like, if you go to a Safdarjung hospital or AIMS, you will see there are multiple buildings housing different kind of departments. So we need to have a disaster management plan and evacuation plan addressing each and every floor of the building, and make sure that these evacuation plans are pasted in all in everywhere on all the floors, especially in each and every room, so that the occupant of that particular area, they know how they can escape in case of there is any kind of an emergency. And once the plan is ready, see, having a plan is not sufficient enough. You need to test your plan. How will you know if your plan is actually effective unless and until you test it? So, like I said, you test the plan in the form of a mock drill or preparedness drill, or if you cannot do that, at least sit for a simulation exercise or a tabletop exercise where a group of hospital administrators will sit together and discuss a disaster scenario and will respond as per their plan. Once your drills are done, once your simulation exercises are done, please make the necessary changes in the plan. Your plan is a living document. It will never finish. The plan that is prepared today will probably change tomorrow or 6 months after. So it is a living document. It will keep on evolving. So one-time effort has to be put in to develop the plan. But after each and every drill or a tabletop exercise, you should work on evolving your plan and changing the plan as per required. Another important thing that we see in hospitals, especially in health facilities, are active fire protection systems such as sprinkler systems, smoke detectors, fire extinguishers, hose pipes. So make sure your hospital has or your health facility has these provisions installed and in working condition. You must have seen in most of the buildings there are smoke detectors with a small red light blinking over there. Many times, what we have observed, These lights are not blinking, and that tells us that the system is off. The system is not working. So make sure that the system is functional and is operational, and you should test the system on regular basis, and it should not be done without telling the building occupants. You announce it that you will be testing the system. And how do you test it? You just put some smoke in front of it using dhoop or agarbatti, or like just burn some papers, and it should activate. And that will tell you that the system is operational, and it is linked with your fire, your security alarms, your gates, and everything. So that is how you can test your system. Apart from having smoke detectors, fire extinguishers, what you also need is to identify refuge area. That this like that when people evacuate, where do they evacuate to? You cannot evacuate all the patients. We need space and we need time. So make sure that you have enough refuge areas in different parts of your hospital, so that people and patients can be accommodated over there. There will be many patients who are bed bound, and you need to accommodate those beds along with those patients over there. So identify these refuge areas beforehand. A number of times I have seen this thing, that during emergency, a hospital is using a refuge area outside the hospital facility, but during a non-emergency time, that refuge area is being used as a parking space. So during emergencies, they don't announce. So if in case something happens abruptly or suddenly, in that case, there won't be time for you to move the vehicle. So identify the refuge area that is always clear of any obstruction. Another important thing, please make sure that you have wide staircases. Now, another important thing that Chandan sir was also talking about, that when the buildings are being designed, and if they are being designed as per the building codes, then you don't have to worry, because our building code, they specify that if this is the number of people who are going to occupy the building, these are the things that you have to follow. So make sure your buildings are designed as per the building codes. And very important thing that we have observed, that even though you can have the widest of the staircases, but a lot of time what people do is they obstruct the staircase using flower pots, or sometimes they put some clutter over there, or sometimes they put some non-usable equipments over there, and they block the exit. That should not happen. Please make sure your staircase and your exits are clear of any obstruction, so that people can move out very easily. Emergency lights with power backup or battery. These are very important. You all would have heard that in case of a fire, first thing that you need to do is switch off the power supply. Many people do that. It's important, it is necessary. But in case of fire, we have a lot of smoke also. And these lights, they will function on battery, and they will provide light at that particular time when there is smoke and pitch darkness. So we need emergency lights in strategically located along our exits, so that in case there is any situation where you have to evacuate during smoke or a fire, then these lights will guide you in the right direction. Another important thing is having glow in the dark and emergency signages on in required places, mentioning that particular door is a fire exit, or the nearest exit is in this direction, especially, and the way they are located. That is very important. Always remember, when there is fire, there is smoke, and smoke being hot air, it will rise up towards the ceiling. So to see, you will have to stay low towards the ground, and that is why in the picture in the right, you can see glow in the dark picture with arrows pointing in the right in the direction of the exit, pasted towards the ground. So whenever you are providing such provisions, please make sure they are provided strategically in exact location where they can be actually useful and helpful. Another important thing that we have observed during over the last few years is disposal of flammable waste. A lot of uh, our hospitals, whether it's a 10-bedded hospital or a 1,000-bedded hospital, it will generate waste on a daily basis, and most of this waste is combustible. Believe me, our hospitals have a lot of combustible material. Nowadays, you have a lot of sanitizers, and sanitizers contain alcohol, and these are something that can burn very easily. And because hospital environment is also rich in oxygen, so if there is a fire, fire needs oxygen to burn, and an oxygen-rich environment will actually help the fire to spread very fast. So make sure all your flammable waste material are disposed of on a regular basis. A few months back, I was in a hospital, and we were checking about the waste over there, and they said that they remove the waste on a weekly basis. We were very happy. Then they took us to the place where the waste was being collected. When we reached over there, we realized that the waste was not picked up for at least 2 months. So you have to make sure that when you are going around your hospital, there are no place where such kind of waste is being accumulated, or and it has to be disposed of on an immediately basis, and it has to be kept away from the hospital, so that even in case if it catches fire, the fire will not spread to the hospital. So waste disposal and keeping hospitals away from such flammable waste is extremely important. That is all I'll discuss about fire today. Now I'll quickly jump to the earthquake and the non-structural risk mitigation that you all saw in the video shared by Dr. Ghosh. You all saw the building was fine. The building developed crack, but there were things that were inside the building that started to fall. The beds were swinging, the cupboards were moving in different direction. They were falling. There were objects in racks that were coming out. So these kind of things starts happening during an earthquake. One thing that people need to understand is that if your buildings are designed as per code, as per the building codes, you don't have to worry about the building coming down. You all would have seen the recent Turkey earthquake. A number of buildings came down, but you also need to understand a number of buildings also stayed up. We all have whenever you see in the news, they will show you the picture of calamity with everything has been destroyed. But there are things that have survived as well. So, like I said, if your buildings are designed as per code, you don't have to worry about building coming down. Building might develop some damage, might develop some cracks, but it will not fall. But there are things that are inside the building that is what we have to worry about, and especially in a hospital environment or a health facility environment, there are a lot of things that can happen and that can cause a lot of issues. So one thing that you need to understand, there is no place in this country where you cannot feel the earthquake shaking. You all would have heard about different zones of earthquake. We have 5 different zones, and there is no zone 1. It starts from zone 2 and goes to zone 5, having the maximum risk. And these zones are talking about the amount of shaking that one can feel in a particular place. So there is no place in this country where earthquake shaking cannot happen. So earthquake happening in any particular part of the corner of the country will cause some shaking or the other in another part of the city, the country. So our hospitals hospital has a network of basic utilities, and these utilities are so interlinked with each other that they assist in the continuation of medical services. For example, water, electricity, medical equipment. So if I say if a hospital has a number of medical equipment and most of them are running on electricity. So if there is no electricity, your medical equipment will not work. Then again, a lot of almost all the hospitals, they need water. If there is no water, your medical services will be disrupted. And without medical equipment, surely there's no hospital. So when we are talking about non-structural safety, we are talking about things that are inside the building that are not part of the structure. The structure, when we are talking about the structure, I'm talking about the beams, the columns, the wall, the roof, everything that is inside. That is part of the non-structural safety. Uh, earthquake resistant hospital buildings are not enough to ensure that the facility remains functional. Like I was discussing, if there is any disruption in your electrical supply or your water supply, or if there is some disruption in your medical supplies or medical equipment get damaged, you saw in the video how things were falling. So in that case, your hospital will stop functioning. So let us see what happens inside a building. I'll quickly show you a video. This is from Kobe earthquake 1995 that happened in Japan. You can see in this video, the moment the earthquake happens, this is the CCTV footage. You see how things started to roll on the floor and started to fall. Just watch carefully at the bottom of the screen. There is a man lying on the sofa. That man falls off the sofa during the earthquake, and just the moment he falls, a cupboard falls on top of that sofa. You can see everything is getting destroyed. The building is fine. It's the things that are inside the building that are falling. So you can see in this picture, the building is fine, but I want to know, will you be able to work in such a hospital where the false ceiling has collapsed, the pipes have broken, the electrical lines are hanging loose? You cannot. You need space. You need space to move patients. You need electricity. You need water. And according to WHO guidelines, if you go through WHO guidelines, a hospital needs 300 liters of water per bed per day. So if there is any kind of leakage or damage to water pipeline, the water will start pouring out and will fill your corridors like this, and it will not be a hygienic environment to continue to function for a health facility. So lives will not be, you will not be able to save lives in such kind of a setup. I'll quickly like to talk about an earthquake that happened in 2017 in Iran. Uh, During the earthquake, one of the hospital director, he explains the earthquake as the the roof started to shake, and he said that the table started to dance. That is how bad the shaking was. Things were moving abruptly in different directions, and he got to know that one of his hospital buildings was severely damaged. And by the time they were able to move all the patients out towards the safety, new set of patients started to come in, because that is what hospitals do. They provide medical care, and to provide medical care you need to be in a functional situation. If you are not functional, you will fail. You will not be able to provide medical support to the community that you are serving to. We saw uh, especially after an earthquake, we have a lot of trauma injuries, a lot of traumatic injuries. We need for such kind of traumatic injuries, we need radiology equipment, MRI, CT scan, X-rays. And if your X-ray machines, this because of the shaking, they start falling like this, your op- your radiology department will stop functioning. And if your radiology department stop functioning, you will not be able to treat these people who are coming with injuries to you in the aftermath of a major earthquake. And many a times it is not just the earthquake that causes the damage. Strong winds, even things fall by accident. You bump into an almirah or a rack and things starts falling. It happens. It is very common. But in such a setup, if something like this happens, it can cause a lot of disruption. And what we are going to discuss next will actually help you prevent it from happening. Uh, I was discussing about breaking of water pipelines. You would have seen in hospitals, in health facilities, pipelines, whether it's oxygen or whether it's water or even wastewater going from one building to the other building. And during an earthquake, both the buildings are going to perform in a different manner. They are going to move and shake in different directions. And when that kind of shaking happens, what happens is this pipeline is also going to move, and it will cause some kind of a breakage, because most of our pipes are either PVC pipes or sometimes they are iron pipes, and they don't have that kind of a flexibility, and they snap. The moment they snap, all the water, all your gases will start leaking, and it will disrupt the entire services in the hospital. Unless and until you repair them, that takes time, your hospital will remain non-functional. Your electrical equipment, you all have seen such kind of electrical cabinets in your electric room, or close to the generator room, in your health facilities, or in any kind of multi-story facility that you are residing in. And if such kind of equipment start falling, it can cause fire, it can cause short circuit, it can start a fire. People will not be able to enter the room unless and until the electrical supplies are switched off. And the moment these electrical panels they start falling, they will pull the wires. That is how the short circuit happens. So you would have heard after a building collapse, fires have started. Why? Because the electrical power lines they got pulled causes a short circuit. There were sparks. Something or the other caught fire. Now it is burning. So that is how a fire starts after an earthquake. So if something like this happens, all of our health facilities are using emergency power backups in the form of generators. And wherever we have traveled, whichever hospital we have traveled, we have seen really big, really nice state of the art silent generators, and they all have been kept in very nice good places, but they are not anchored. They have space that is required where you have to bolt them to the ground, but they are not anchored. They are just kept over there, and people believe because they are so heavy, nothing will happen. You I have heard this thing personally when I tell that, okay, your generator is not in a safe position, or your battery backup is not in a safe position, it can fall. And people say, no, it's really heavy, you cannot even push it. But please, people, believe me, when there's an earthquake, it can push buildings. So, you know, your generators, your power backups, your battery backups, they are nothing in front of it. So all of these things will actually move. Sadly, the thing is, we personally have not seen a lot of this happen, but the reality is that it does happen. It has not happened to you till now. That doesn't mean it will never happen to you. There is always a first time for everything, for every one of us. So we must learn from places or from people who have actually seen it happen, so that we can prevent it from happening in the future. You all must be aware. Why do you wear a helmet while riding a two-wheeler? The reason why we wear a helmet is because we need to protect ourselves. We need to protect our head in an accident. So for that reason, we wear a helmet. It is not necessary that everyone has had an accident, but still we wear that helmet. So similarly, when we are talking about non-structural risk, we need to understand that these are the things that can actually happen. It has not happened yet, but in case of a violent shaking, if this thing falls, or even by accident, your hospital facility will be disrupted. So, what the best strategy? The best strategy is to do it right in the first time. When you are constructing it, when you're constructing a health facility, you consider all these things beforehand. Now, the thing is, most of you are already part of various health facilities which are already existing, which are already there. Now, what can we do? So the second option that you have is, when there is some remodeling, or some updation work are happening, some retrofitting, or some kind of new things are being added. You please make sure that you fix the issues then and there. But apart from that, there are many other things that you can do on your own in your own room using few basic tools. So let us start with autoclaves and sterilizers. In a hospital setup, we have CSSG room where such kind of equipments are placed. And these equipments are extremely important because they sterilize all your medical supplies. And for any kind of operation or any kind of other services, you need sterile environment, you need sterile devices. And what if these equipment they start falling? These equipments are also plugged into electrical sockets, and they are also attached with water pipelines. So when they will fall, they will cause disruption of water, they will cause disruption of electricity, they can cause short circuit. And if something happens to this particular equipment, you won't get sterile devices, sterile supplies. So what we have done over here is, this is the example that how we can fix such kind of equipment. You just anchor them to the ground. As you can see in this picture, we have a autoclave, and we have made these clamps. If you can see the pointer I am showing, you can see these U-shaped clamps, and we have just put them on all the sides of the autoclave and bolted them to the ground. Now, no matter how much hard you push or move it, it will not move. And these are such kind of equipment that once that they are placed in a particular area, they are not moved for a long time. And just in case if you plan to move them, you just have to remove the screws and remove the clamps and shift it. And wherever you're going to take it, just do the same activity all over again. OT lights. See, in a hospital, there are n number of equipments. We will be discussing few because of the time constraint, and I'll be giving you a link to a book that you can access for free and download, and it has each and everything that you can find in a hospital, and it has the solution how to fix it. So coming to back to OT lights, these are really heavy lights. They are attached to the ceiling and they have swinging arms. And what happened is during the shaking, because they are disproportionately balanced, they sometimes they break. And if they fall on patients or the medical staff who is busy in the OT at that time, it can cause a lot of issues. We don't want our medical staff, we don't want our patients to get injured. So what we need to do is that we need to fix them and anchor them well in advance. Like I was mentioning, in many places, in many hospitals, this is what we have seen. All the hospital equipments, whether it's your CT scan or your MRI machine or your X-rays, even portable X-rays, they have provision considering earthquake shaking, or just so that they don't slide. And they have provisions that we can anchor them to the ground. But many a times, people who are installing them, they don't anchor them. And that is a big issue because people don't understand that why these anchors are important. If your MRI machine is dislocated during an earthquake, or if the electrical panel that is on the other side of the MRI machine in another room, if it is dislocated and it falls, you will not be able to use your MRI. So make sure your equipments are well anchored. So like I was telling about the OT lights, they need to be well anchored to the roof. Coming to laboratory and some other equipment such as refrigerators and uh, laboratory equipment, basically, these are the equipment that are used on a daily basis in a health facility. But one thing that we need to remember is that these particular equipment we can also shift, and they are easy to be lifted. Sometimes we can easily lift them and keep them in a different location, or sometimes we have to for example, over here we can see a microscope. Someone using it on another table, they can easily put it up and take it over there. So we cannot anchor them, we cannot drill a hole through them and just fix them to the table. That we cannot do. So what can we do over here? You all would have seen velcro, something that is sometimes also used to tie our shoes or our belts. So that kind of solution can be added over here. We have a male and a female part of the Velcro. Just place one side on the table, the other side on the bottom of your equipment, and just put it on top of them each other. Now, I'll show you a video after this. No matter how much you shake the table, this thing is not going to move very easily. Another thing that you can add is a non-slip mat, a rubber sheet. It comes in various sizes. It is very easily available in the market, and it comes in various sizes of various thicknesses. You just put it over under your equipment and keep your equipment on top of it. that will actually provide it additional friction. So in case of an earthquake shaking, it will not slip or slide in any direction because of that friction. If some of you are using your laptops, you just lift your laptop and see four there are four rubber pieces attached under your laptop. This is the kind of rubber sheet that I'm talking about. You can either put the entire sheet or you can cut four pieces and just paste them under your equipment and leave your equipment on any table or any place, and you can push it as hard as you like. They will not budge very easily. They will move, but they will take a lot of effort rather than equipment without any provisions of such kind of sheets. When we have provisions of cupboards and racks, and all these cupboards are filled with medical supplies. We don't want these cupboards and racks to fall on our medical staff members, because if they start falling on our medical staff members, chances are they will not be able to provide any kind of medical assistance. Plus, there will be a lot of damage and loss of property in the form of loss of medical supplies that are being kept in these cupboards. So, what we can do is what we can do over here is we can anchor these cupboards and racks to the wall. If you are not planning to remove them from a particular place, you just put some clamps over there, like this man is putting it on this rack. You drill a hole in the wall, you drill a hole in the cupboard and put a bolt over it, and that's it. You just put some clamps on all the three sides, and your cupboard is fixed. You close the cupboard. Now you can shake as much as you like. This cupboard is not going to move away from the wall unless and until the wall gives way. You might be
Pranav
thinking
sir,
about, yeah,
5 minutes more.
yeah, I'm about to finish. Thank you.
Okay.
Uh,
Yeah.
uh, okay, you might be thinking that what do we do about the refrigerators? We cannot drill holes, or ovens, or such kind of expensive equipment. We cannot drill holes into them. So what do we do? Over here, you can see this man fixing the refrigerator. They have used three different types of L clamps, three different long L clamps. They are just put it on the wall as per the size of the refrigerator and push the refrigerator inside. Now, no matter how much you do or whatever you do, you can push this refrigerator in any direction. It is not going to budge from its spot. They are not drilling a hole in the refrigerator. They are just creating a small compartment in which it has to be fixed in and left it over there. That's all. Then we have supplies on trolleys and gas cylinders. So what we can do over here is, as you can see, in this particular rack, the hospital has first fixed the rack to the wall, and then they have put a plexiglass plate in front of it, so that even if something happens, even if there is any shaking, these medical supplies, these medicines, they are not going to slip and slide and fall outside. As you can see over here, they have put a wooden block in front of it so that it doesn't come out. Another simple solution, all of you would have seen this wire at your home some or the other time. This is called a curtain spring or a curtain wire. And if you can just put it in front of all your racks, just like, put a screw on both the ends, tie the wire to it, and that's it. This is going to help all your medical supplies to stay intact and inside the racks and not come out. Not just your medical supplies, even your books in bookshelves. Many hospitals have libraries. Just put it in front of them, and so that your books doesn't come out. Your books can be pulled out easily, but in case of shaking, it will not slip out. Just like this, or in this particular picture. So this is the video I was talking about. This is a video of a school principal's office where we have a rack at the back of the principal's chair, and we have very heavy trophies on top of it. What we did over here is we didn't screw anything. We didn't paste anything. We just fixed these trophies using Velcro and rubber sheets. And you can see in this video, no matter how badly you shake it, it will not fall. So talking about pipe ducts and conduits, we have a lot of pipes in our hospital, oxygen pipeline, water pipeline. So in this case, what happens, like I was telling you, when the pipes are traveling from building to building and these pipes are not flexible, they can snap during shaking because each building will be shaking in a different direction. So to prevent them from breaking, what we do is we provide some flexibility. And how do we provide flexibility? Just add a rubber pipe or a flexible pipe connection in between. So if you can see in this picture, this is a picture of uh, uh, fire pump room. They have added these black color joints in between. These are joints which are flexible. And on the right, if you can see, there is a silver colored pipe over here. It is a flexible pipe which has a rubber lining inside and a silver wire outside. And these pipes are so flexible that even if you move the motor and the pipe in different direction, it will not snap or it will not break. It will bend, but it will not break. And this is how you can prevent any kind of leakage of water or any kind of leakage of any gases by providing flexible joints. So, like I was telling you, you can download. There is a book that is freely available called Reducing Earthquake Risk in Hospitals from Equipment, Content, Architectural Elements, and Building Utility Systems. It's a book that we prepared, and you can download it. You visit our website geohas.in and go to the hospital safety page. It is free of cost. Just go over there. You can get in touch with me, and I'll be very happy to help you out over here to help your hospitals prepare for such kind of falling hazards and for fire safety. That is all from my end. Thank you. And I'll be very happy if you have any queries. I'll be very happy to take them over the next few minutes. Another thing, share just 30 seconds. Uh, Whatever you learn today, it's not just meant for your health facility or your hospital. It is something that you have to take back home also. All these equipments, all these pipelines, all these racks, all these cupboards, they are something that is something available at your home as well. Or fires, they are not just limited to hospitals, they can happen at your home as well. So to prevent such kind of features, start from your home. Start today so that it is fresh in your memory so that you can actually save life, or else chances are, you might remember me when you actually have to face such kind of an event. Thank you, everyone. Thank you so much for your time. That is all from my end.
Thank you so much, sir, for discussing all these elements related to the fire and earthquake in very detailed manner. Not only the major causes of fire or earthquake, you also discuss what are the different easy and available methods by which we can prevent these issues and we can prevent a major disaster. So thank you so much, sir. And the participant, I'm seeing that a lot of you are discussing in the chat box. That is very good. And you can also put your questions if you have any for the our speaker. Sir, if you are going to stay, then I think we can finish both the session and we can take the question and answer together
Yeah, I'll
as
I'll
we have
be
planned.
here. I'll be here, Shreyas.
Okay.
I'll be happy to take all the queries
Yes.
later on also. No issues.
Yes.
I'll
So
try to answer the questions in the chat also in the
yes.
meantime.
Okay, fine. So you are discussing participant. That is very good because if the participants are attentive, that is a very beneficial for the webinar also that we are fulfilling our objective. Yeah, that is good. So moving to the next session. After this, we will take all the question and answer. Uh, so the next session will be taken by Dr. Nidhi Yadav. She is a doctoral in hospital management with specialization in disaster management. She holds her master's in hospital management with specialization in quality management from the prestigious Indian Institute of Health Management and Research from Jaipur. She is currently working with International Institute of Health Management Research, New Delhi, as associate professor. Dr. Nidhi has experience of 13 years, more than 13 years in hospital operation and quality management. She is a seasoned academician, researcher, and medical quality administrator with the zeal to bring tangible changes in the way quality of disaster management is perceived and practiced in the health care industries. So with this brief introduction, I would like to request ma'am to take the session. She will going to discuss on disaster management plans for the hospitals. Over to you, ma'am.
Thank you for the kind introduction, Pranav. Shreyesh. And thank you, Pranavji. You have set the tone really well and have put a lot of queries, a lot of areas of concern in the mind of the participants, the listeners. I'll try to do the procedural part of the disaster management planning for the hospitals so that they get some answers to those queries by the procedural from the procedural angle, and together joined with each other, procedural and structural and non-structural, the hospitals can become really actually resilient in nature. So the whole idea of having these two sessions, I think, Shreyesh, is to have a resilient healthcare infrastructure, which I think at the end of the session, the participants will be able to appreciate. I want to thank Professor Chandan Ghosh ji, Dr. Garima Agarwal for having me here, giving me this opportunity. And I'll try to do justice to the subject, to the topic given to me. Okay, now I'm sharing my screen. Is my screen visible to everybody?
Yes, ma'am.
All right. So I'll just take you through the magnitude of disasters at global level. We all know disasters are something which do not spare anybody, and they are like they have affected approximately 1.4 million, that is approximately 14 million people life in terms of deaths. They have caused deaths of 14 million people, 1.4 million people till now, and the losses due to natural disasters are approximately 20 times higher in terms of GDP in developing countries as compared to the developed countries. This is the statistics which should not let us sleep. This is such a grave statistics. So, and India being a developing country is extremely vulnerable to disasters. Why? I'll come in my next slides. Asia being the biggest continent tops in the list of deaths due to the natural disasters, of course. And the record of natural disasters is not new. We can trace it back to the history. When in 1430 BC, there was a time when typhus epidemic broke in Athens and claimed several lives. And the 10 deadliest natural disasters which could be recorded in the world history could be dated back to 1556, when the earthquake of magnitude 7 hit the Shanxi province in China and caused death, claimed the lives of approximately 830,000 people. If we divide the disasters by nature and number of deaths, the hydrometeorological type of disasters, which are caused by water and other meteorological reasons, are among the top, and so are the deaths caused by these hydrometeorological disasters, followed by the geological kind of disasters, and the last is the biological kind of the disasters. So management of disaster becomes a major area of concern at global as well as at national level. So it is this statistics is irrespective of where we are sitting. It is world over statistics. Be it developing countries, be it developed countries, the disasters, the hydrometeorological type of disasters hit us hard and do not spare us at all in terms of the magnitude and the intensity. The overall aim, coming to India now, after the global things, in India, we are vulnerable to varying degrees of disasters, especially man-made disasters also, because our 58.6% of landmass is prone to earthquakes of moderate to severe intensity, and approximately 12% of our land is prone to rivers and river erosion and floods. We have a long coastline of 7,500, out of which approximately 5,700 is prone to cyclones and tsunami. We are prone to droughts in hilly areas because we have approximately 68% cultivable land in India, and there is a huge risk of landslide and avalanches across the countries because we have 14 states in which the Himalayas run. 14 states. So besides that, we are vulnerable to disasters, emergencies of CBR in nature, chemical, biological, radiological, and nuclear, which is another set of disasters which are man-made in nature partially, and they can occur in the same way and cause a lot of casualties and damages and disaster and losses to us. Another thing is we have sideline of events like population explosion, urbanization, industrialization, unplanned growth in the high-risk zones, environmental degradation, climate change. They all add on to the vulnerabilities to the disaster risk and make us even more prone to these kind of disasters. Not going very far. So the overall aim of disaster management, be it natural, be it man-made, be it any kind of disaster, small scale, large scale, countrywide, across the cities, across the states, in the household, wherever we see it, is to reduce the potential losses from hazards, assure prompt and appropriate assistance to victims whenever necessary, and achieve rapid and durable recovery. These are the three main aims of disaster management of any type, any nature, any magnitude, any state, any country that you talk about. So this is the cyclic nature where we prepare in the first phase. Preparedness is really costly in terms of dollars. If we calculate, preparedness cost us $1. However, recovery and reconstruction, if we talk of this phase, recovery and reconstruction, it cost us approximately $7 as per WHO impact report. So preparedness is anytime cheaper, anytime, and this loss does not amount to the life loss. This is only the damage, the financial and economic damage that I'm talking about. So $1 is anytime cheaper and pocket friendly as compared to $7 in terms of the recovery phase. So we need to really thrust upon the preparedness, which is the theme of this webinar as well. Now, what is happening in disaster management at global level? You know, the first development at global level took place in the form of Yokohama strategy. I'll share these slides with you and you can actually go back and study the Yokohama strategy, which talks about, which gave us the guidelines of natural disaster prevention, preparedness, mitigation, and its plan of action, and was adopted in 1994. Followed by Hyogo framework of action. It spanned from 2005 to 2015, and its emphasis was on building the resilience of nations and communities to the disasters. And now, from 2015 to 2030, we are looking forward to the declaration that we have taken in Sendai framework for disaster risk reduction, which was adopted in 2015 in the third United Nations World Conference on DRR held in Sendai. These action frameworks had representations from the member states of United Nations, and India is a signatory in these frameworks, and we work really closely with UNDRR, United Nations Disaster Risk Reduction, to implement the priority areas of these frameworks. So it is very important to us to know what is happening at the global level and how India is contributing towards it and gaining from it, basically, both sides. At India level, 1990s was declared as the International Decade for Natural Hazard Reduction. After 9 years, a high-powered committee report came to India, suggesting that we need to have preparedness and mitigation measures for natural disasters. In 2002, the Disaster Management Division which was established under the Ministry of Agriculture, was shifted to Ministry of Homes. And based on this high-powered committee report, in 2005, the Disaster Management Act was enacted. This act came into force and was gazetted in December 23rd, 2005. This is setting the tone for the disaster management at India level. Now, following the enactment of this act, Disaster Management Act, what all happened is the NDMA was established, the National Disaster Management Authority, chaired by the Prime Minister, Honorable Prime Minister himself, followed by establishment of state disaster management authorities headed by the Chief Minister of the respective states, district disaster management authorities headed by collectors, district magistrates, deputy commissioners, etc., and the NIDM was established for capacity building and training. The chronology of event, if you could see, is establishment of the act. Then what Dr. Garima told us was like National Disaster Policy, Disaster Management Policy 2009 came up. It was revised in 2016. And finally, we were given the Hospital Safety Guidelines 2016. So all hospitals should comply with these guidelines as per the mandate of the act. However, since 2016 till date, we really lack in implementation of these guidelines. These guidelines, if implemented in letter and spirit in our hospitals, our healthcare facilities, irrespective of their size, structure, accreditation statuses, will really make the health infrastructure safe. We'll take up these guidelines in my session slowly. It is very difficult to cover these guidelines in one session. So let me see how much I can cover in this session. The overall aim for the disaster management plan for any hospital. Let us now come to the hospital. After this disaster management guidelines, now I'm coming directly to the disaster management plan for a particular hospital. And what does the plan aims at? To effectively treat the largest possible number of affected victims, efficient integration and use of available staff and equipment, to control large number of patients and the resulting problems as efficiently as possible, to treat patients based on the rules of medicine despite of greater number of patients. This is the basic premise and should not be forgotten. To ensure ongoing proper treatment of the existing inpatients who are already registered and admitted at the facility, to smoothly handle all additional tasks caused by such an event, maybe the damage related to it, maybe the reconstruction, recovery, the post-traumatic stress disorder, the lack of supplies, the lack of inventory that we face, etc. So parallelly, we have to handle that also. To support the triage area by means of medical consultation, medications, infusions, dressing, etc., all sorts of medical supplies, and to organize adequate human, material, and financial resources and relocate areas appropriately. So this is the broader aim, of a disaster management plan. And whenever you weave a disaster management plan, which Pranav was talking time and again in his session, you have to keep these things in mind. So before we go ahead with the weaving of the plan, we should really know where my hospital is sitting, what are the hazard characteristics of my hospital, and what are the hazard and vulnerability risks facing my hospital. For doing that, I need to have a profile of my hospital. What was the year of establishment of my hospital? Since how many years is it functional? Was there any gap between the functionality? Was any retrofitting being done in the hospital and it was shut down for a couple of months or years? What are the number of operational beds? What is my current bed occupancy percentage? What is the hospital surge capacity? How much expansion of hospital can I do in the event of a disaster? A number of beds in particular specialties like medicine, surgical beds, intensive care beds, emergency operation theaters. So I need to really have this data at my hand while developing my disaster management plan. I have to keep that in my right hand and then keep writing the disaster management plan. For the hazard profiling of the hospital, what is a hazard? Basically, it is a potentially damaging physical event, phenomena, or a human activity that may cause the loss of life or injury, property damage, social and economic disruption, or environmental degradation. So, hazard may not be really something coming in a large way to your hospital and hitting it hard. It may be any amount of economic disruption caused by any event, any amount of environmental degradation caused by the particular event. So, the origin of the hazard could be geological, hydrological, meteorological, biological, etc., or maybe induced by human processes like environmental degradation, technological hazards, etc. If I have to classify the hazard elements, potential hazard elements that could face my organization, I really need to look into 6 aspects. That is geological hazard, maybe an earthquake, am I prone to earthquake, how much, what is the Richter scale frequency that my hospital is sitting onto, that you can really find out from the seismic mapping of your hospital. Volcanic eruption, is there any potential dormant volcano nearby my hospital, and at what level, primary catchment area, secondary or tertiary. Then landslide, what is the probability of landslide, tsunamis and others, cyclones, etc. Any other hydrometeorological hazard like hurricanes, torrential rains, storm, river flooding, even now urban flooding, etc. Social phenomena like population gathering, displaced population, VIB movement in and around my hospital, that can also lead to disastrous effects on my healthcare facility. Then environmental hazards like epidemic, contamination of the water source, infestations, others, etc. So any hospital which is near a chemical factory, or maybe a cement factory, a paint, or kind of explosives being manufactured or stored or housed, or any warehouse which carries all these chemical storages, that they really need to look around the environmental hazards that can be caused because of these elements, and the potential casualties or the infected or affected population that can come to the hospital for treatment. Then chemical and technological hazards, for example, explosions, especially in industries, factories, etc., fire hazards, hazardous material spill and others. Then geotechnological properties of the soil also needs to be studied. What is the possibility of soil erosion? Is my soil, how unstable are my slopes? What is the characteristic of my soil? Is it loose soil? Is it loomy soil? Is it black soil? Is it hard-bound soil? What kind of a soil that is there in my area in which I have constructed my hospital? So basis these hazard elements, I can have a very good idea of the potential hazard elements that are facing my hospital and the probability of each hazard affecting my hospital. So I have to really calculate the probability of each hazard element which may affect my hospital. Once that is done, we move towards the expected disaster scenario for a particular hospital. So hospitals may face both internal and external disasters, and the impact of internal disasters. Internal is something which affects only my organization, my healthcare facility, and it does not come from outside. It is generated inside the organization because of some or the other malpractice, or some or the other faulty practice, some or the other breach of procedure, some or the other failure in the procedure. Exposure to hazard material, utility failures, etc., and is typically limited to that hospital or healthcare facility. On the other hand, the external disasters include scenarios like earthquake, mass casualty events, or epidemics, where the hospital itself may or may not be affected, but is critical part of the larger response. So in such situations, where we can expect three kind of scenes which a hospital could face. First one is the community is affected, but the hospital is unaffected, which means the disaster has happened and the community at large is affected, but the hospital is unaffected. During such scenarios, hospitals play a really vital role in the larger disaster response being undertaken. And for hospitals, such scenario would imply a sudden increase in the demand of healthcare services and a surge in the patient coming to them seeking medical attention. The second scenario could be community is unaffected, the hospital is affected. That means the internal disaster has taken place, some sort of internal crisis or emergency situation has happened in the hospital. And in such situation, partial or complete evacuation of the hospital and healthcare facility, along with the transfer of the critically ill patient to another facility, needs to be carried out. So you need to have a really strong network of hospitals with you at your disposal, where you can transfer your critically ill patient or your inpatients for continuity of care. Third scenario which can happen is expected scenario that we can foresee is the community is affected and the hospital as well is affected. That means the disaster event or the hazard event is of such magnitude that not only the community but your hospital is also equally hit. And such situation actually poses a bigger challenge to the hospitals, and they need not only cater, because in such situation the hospital actually do not have to cater to the existing demands of the inpatients and but also to the community patients which are coming from the community. The inflicted community actually looks upon the hospital as a support mechanism for medical care. And in such situations, the hospital may even find themselves being faced by a challenge of loss of the essential services because they are hit, loss of the manpower, and essential supplies like water, electricity, medical gases, food, linen, etc., because they are cut from the community. The roads are broken, the landslide has taken, the roads are blocked, or maybe the water has, the flood has inundated the supplies housed in the basement, or stores, etc., are flooded. So the community is affected and the hospital itself is affected badly. So the only rational manner in which a hospital can be prepared for disaster is by increasing their resilience and reducing their vulnerability. All in all, it will be helpful by strengthening both structural and operational aspects of the hospital so that they achieve the desired degree of safety. The ultimate goal is we have to achieve the desired degree of safety in the hospitals. Now coming on, what is a safe hospital? I just talked about safety of the hospital in the last slide. A safe hospital, as defined by PAHO, the Pan American Health Organization, and the World Health Organization, should be the one that will not collapse in the event of disaster, killing its own patients and staff. First premise is it should not collapse and should not kill its own occupants. It can continue to function and provide its services as a critical community facility when it is most needed. So whenever a disaster strikes of any nature, the only critical facility that is looked upon is a hospital, and it should serve so. It should live up to that expectation. A hospital is organized with contingency plan in place, and health workforce should be trained to keep the network operational. So these three elements put together in a triangle makes a hospital safe. Why we need to have a safe hospital besides all the factors that are being discussed? The prime reason is a multi-speciality and well-equipped hospital holds enormous amount of investment. Bringing up a 100-bedded hospital is very costly, and if the bed strength increases further, it becomes costlier because they house a lot of costly equipment, supplies, etc. And destruction to this hospital structure poses a major economic burden on the affected society. Also, it causes a lot of stress in the society, because hospital is looked upon by the society as a care provider. Any damage to the hospital structure is actually very stressful for the community. There are a lot of studies on that also. So making hospitals safe from natural disasters require not only one person approach or a one book approach, but a multidisciplinary expertise of a variety of experts ranging from engineers to architects to administrators to the Safai Karamchari of the organization. It should start from, it should involve everybody, no one to be left behind. And this concept of safe hospital does not merely refer to physical and functional integrity of health facilities, but also the preparation of functions to full capacity and cater to the needs of the affected community immediately after the disaster strikes. To meet all these things, to ensure that these hospitals, safe hospitals, the hospital becomes safe and keeps running, keeps functioning, and continues providing the necessary health services during and immediately after the emergency, we need to have a Hospital Disaster Management Committee, HDMC, who should be responsible for developing the Hospital Disaster Management Plan, HDMP. And the members of this disaster committee, HDMC, shall be trained to institute and implement the Hospital Incident Response System, HIRS, Hospital Incident Response System, for both internal and external disasters. So at this stage, on this slide, when I'm talking, we have the HVRA of the hospital in the hand. I know what are the hazards facing me. I know the probability of the hazards that are there in the in my vicinity, the probability. Then I have the profile of my hospital, the bed strength, the capacity, the functionality, the history and geography of my hospital. And now I have a functional committee who is ready to make the disaster plan using all this background information. So how that disaster plan will be weaved around, we will see in our upcoming slides. The plan which I'm talking about right now has to be weaved around all these things. Coordination and management, planning, training and drills, information and communication needs to be addressed, safety and security issues needs to be addressed, human resource needs to be addressed in the plan, logistics, supply and finance management needs to be addressed, continuity of essential services need to be addressed, triage possibilities and protocols need to be addressed, surge capacity of medical response to be addressed, post-disaster recovery to be addressed, patient handling mechanisms, volunteer involvement and management to be addressed, area level networking of hospitals, coordination and collaboration with wider disaster preparedness initiatives to be addressed in our plan. Looking at the coordination and management. So once the HIRS, the Hospital Incident Response System, is established, what are the components to that? We need to have an incident commander. You need to have a public information officer. We need to have a safety officer, a liaison officer, and all of them should be supported by 4 basics which are in the pyramid of this structure, that comprise the finance and administration section, the logistics section, the operations section, and the planning section. All of this put together makes our hospital incident command system. And this system should be ingrained into practice. This system has to be updated and revised and tested from time to time by means of regular tabletop exercises. And the overall objective of the HIRS structure shall be to enable the development of strategies, management of resources, planning, and implementation of operations, or the continuity of operation, rather I should say continuity of operations in the emergency situation. Now this committee, this entire team along with the disaster management committee shall establish the HIRS, or Hospital Incident Response System Manual. It should have a command structure. It should be a modular organization. That means it should be flexible enough to make adaptations as per the needs, as per the changes in the disaster, its magnitude, type, timings, etc. Disaster may strike anytime. Then it should address the consolidated action plans. The consolidated action plans. It should have a manageable span of control. It should have a comprehensive resource management plan. And how am I going to address my resource shortage, ensure my continuity of supplies, and save my existing supplies from being exhausted at a faster rate. Coming on to the next part, planning, training and drills. We have to ensure that our HVRA, hazard vulnerability assessment, risk assessment, and hospital capacity analysis is done beforehand. We have all the data in place along with the probability percentages for each possible hazards facing us. Then we have to plan for each of the critical function meticulously. And the possible responses that we can expect from those functions. They have to develop standards, protocols, and guidelines specific to those critical responses. What am I going to do if my linen supplies goes short? What am I going to do if my fuel supplies go short? How much fuel do I have right now? What is my storage capacity? How long can I run on my existing fuel supply if I'm cut off for 72 hours? Can I sustain the first 72 hours of the disaster event? Then the resource allocation, how adequate resource allocation has to be ensured by the management of the organization for disaster preparedness, trainings, drills, etc. You need to really park some resources for these purposes. Then you have to really invest on your staff in terms of training, hand holding, giving them the flyers, bilingual or trilingual, or in various languages. You have to really display the exit plans. You have to really train your staff in all aspects and build the confidence in them by doing hands-on simulation exercises, mock drills, tabletop exercises, irrespective of the fact that the staff has to be pulled out of their operational hours, operational duties for participation in such trainings. The disaster may happen once, but the staff needs training around the year, and the training needs to be updated from time to time because the HVRA keeps evolving. The disaster plans also keeps evolving, as Pranav also mentioned. And regular improvement in the plan needs to be done from time to time. Any amount of drills that you do, any number of drills that you do for the various type of disaster, you come up with some or the other shortcomings. You learn some or the other variations from the protocol, and that becomes the basis of your improvisation of the plan. So it becomes a cyclic process and an ongoing process. You should not shy away from that. Then we should focus on information and communication. This is really important and should not be overlooked at all. The Disaster Management Committee shall ensure clear, accurate, and timely communication and information management, both for internal and external purposes, to ensure that informed decision making and effective collaboration, cooperation, and public awareness through use of common technologies. Integrated communication system and an efficient alert system is established for the purpose of disaster management. The hospital incident response system shall communicate with not only with the internal stakeholders, but with the external stakeholders like the fire department, the disaster management authorities, key stakeholders like police, etc. Then there is another important aspect in information and communication, that is medical legal case documentation. So the medical legal cases need to be really documented accurately, timely. However, they should not be given prior, they should not bypass the need of medical intervention that is to be done. So medical intervention is the first part of it. However, documentation of the medical care that we are giving is another part of it and is very important. The treatment of patients should not be overlooked or should be given priority over the paperwork. And to meet the surge of cases, additional medical record technicians or additional medical record staff should be posted in the medical record section for that purposes. And sometimes computerized documentation also helps in, faster documentation, easier documentation, and accurate documentation. All this documentation is important, and for the purpose of our in-house purposes, how many patients did we cater, in what time span did we cater these patients, and also in the identification of the dead and right disposal of the bodies, right handover of the patients, right transfer of the patient to the desired facilities. So medical legal documentation is the basis for all the kind of communication that goes in. Anything documented wrong in the patient record can actually lead to a wrong delivery of the patient or the dead body or the transfer of the patient to the respective facility. These are some key points. Then safety and security. The organization should have robust safety and security management processes in place, and they should be applicable to all the personnel in the organization, irrespective of their stature. A Safai Karamchari to a medical director or the CEO of the hospital should follow the safety and security management protocols in letter and spirit, and it should be done in the routine hours also, so that it becomes a habit. You have to follow the particular entry gate of the hospital. You have to assemble yourself in a particular assembly area in the event of a disaster. A particular person should have a roll call register on daily basis, so that in the event of disasters, he can take the head count of his department people under his custody. So all these things have to be followed. Where are the keys placed? Where are the exit doors placed? The exit doors not to be blocked by, as Pranav also mentioned, that they should not be used as thoroughfare, but they should not also be clogged by storing our supplies or other material like almiras and etc. Because we generally feel exits, fire exits or building exits are generally used in the event of disasters, which happens once in 5 years or once in 10 years, or has never happened in my presence in this hospital. So I can park my extra furniture in this passage. So that should not be done. Then applicable, this should be coordinated by hospital disaster management committee, the safety and security management protocol, and they should really work on access control of efficient evacuation plans they should make, and crowd control, which is another very important aspect in terms of the disaster preparedness. Crowd can actually be helpful many a time, because it gives you volunteers, it gives you helping hands, it gives you blood donors, it gives you people with lot of contacts, people with lot of help for evacuating the patient. But at the same time, crowd can pose a threat to you by becoming chaotic, by becoming difficult to manage, by pilfering the things, by taking away the patient without your knowledge, and a lot of other nonsense can happen if the crowd goes uncontrolled. It is beyond imagination what an uncontrolled crowd can do in a disaster hit facility. So crowd management is another key area which the safety and security department has to look, and the entire HDMC should pay special attention to that. Then human resource. The employees of the organization at the beginning should be classified into an essential employee. Yes, I need this employee at the time of disaster. He or she is critical to these services. Yes, this is also an important employee, but he is non-essential in the event of disaster. I can let him be at home or in off-duty hours. I should not call him immediately when the disaster strikes. So I need to classify my employees into essential and non-essential employees, and this should be established and implemented in the HR policies, as which should be a part of the disaster management plan. The HR should actually make a contingency plan for the disasters, different type of disasters. If my 50% staff is hit by disasters, maybe a biological disaster, chicken pox outbreak among the nurses, what will I do? How will I cope up with that? If suddenly my particular department goes on a strike, what will I do? If suddenly half of my staff is down or is not able to work, or is working 24 hours and is not able to take rest, how will I replenish, how will I replace them with the new staff and give the rest to the working staff? So for that, they need to have plans for 50% capacity, 75%, 85%, 100%, and 110%. In case if I have to work at a higher capacity, higher surge in my hospital, then I need to really check the competency of my staff, who I'm going to place in level 1, level 2, and level 3 stages of the contingency plan. How will I manage the shifts of this staff? This needs to be looked into by the HR management, and they should be addressed in the DM plan. The incident commander should be aware of it, like after 24 hours of the disaster, activate plan B of the HR management policy. Things like that. Then measures should deal with post-traumatic stress disorder, which of course happen in the staff who is at the front line of the care provisions. So any staff, irrespective of the nature, he may be essential, non-essential. If he is on ground, and irrespective of the nature, that means if he is medical staff or non-medical staff, the post-traumatic stress disorder can happen to any of them. Vulnerability status of a person varies from the other person. No two people are same in terms of stress management. So this needs to be, this cannot be overlooked, and should be addressed in the DM plan as well. How are we going to provide stress relief to the affected population and the providers also? Then logistics, finance, supply and finance management. In order to ensure the continuity of hospital supply and delivery chain, the following 3 functional areas shall be ensured. One is operations, which means responsible for coordinated tactical response to the event or incident, the operations management team. The logistics management team, they should entail provision of facilities, services, materials, including transport, fuel, shelter, personal hygiene elements, food, potable water, fire suppression water, medical attention supplies, relief personnel, etc. So all these logistics arrangements so that the operational teams could deliver the output, the logistics has to give them a backup. And lastly, the finance and administration. They have to track all the events and the incidents, and they have to actually make the cost estimates on the real-time basis. They have to evaluate the financial considerations for the event and the incident. So when the HVRA is done and the probability of occurrence of an event is attached to it, the finance guy has to sit on the plan and see if this plan, if this disaster, if this hazard hits me at this intensity, probably I'll have this much loss of business, I will have this much sudden requirement of the finances, I have to make available this much of petty cash, I have to make this many local purchases. All these things he has to keep in mind, and then do the budgeting for the disaster management committee, disaster management plan and of the hospital. The key functions of this team, the finance, supply and management team, is to have an updated inventory list in terms of equipment, supplies, pharmaceuticals, etc. And they should have their triggers, the shortage alarms, that now, the particular supply is running short. We are at, 30% level of the supply. We are at 25%. We are at 20%. Now we have to really get the orders replenished, the supplies replenished. Otherwise, we'll run short of this critical supply. They have to estimate the consumption pattern of essential supplies and pharmaceuticals basis the nature of disaster. And they have to establish contingency plans for supplies to ensure continuity of the supplies with the vendors in terms of quicker payment, easy processing of the GRN, easy receival of the product, quick POs being made, purchase orders being made, and they have to actually make provision for the disaster budget. If that is already done, I think these things are sorted. A lot of things are sorted from the finance purpose point of view. And they have to have special accounting protocols. They really cannot follow the tally and one-to-one counting and head counting at the time of the disaster event. The nurse or the consumer of the consumables may not be really able to put the supply, the consumption real time into the HMIS system or into the accounts book, and really cannot reconcile the consumption of medical supplies with the disaster victims while she's attending the disaster victim. So special accounting protocols have to be set for addressing such issues by the finance team. Continuity of essential supplies. The essential supplies for every hospital and facility shall, these should and the hospital facility should ensure that 24/7 availability of routine and normal emergency domestic and treated water, power, medical gases, vacuum, natural gases, heating, ventilation, all these essential supplies which are critical, which are at the back end but are critical to run the normal operations or the clinical operations of the hospital are up. So how do we ensure continuity of these services? That has to be ensured. Where will I get my fuel supply? As I told earlier, where will I get my water supplies? Where will I get my dry ration? Where will I get my potable water from? What is my existing storage capacity? What is my surge capacity? How far can I go? How much can I expand with the existing resources? If with a particular influx of patient in this much amount of time, how much I can stretch? As Pranav also told that we need, as per WHO, 300 liters of water per bed per day. So do I really have that much of water to run my show for next 72 hours in the event of a natural disaster? So continuity of supplies has to be ensured. And this is a part of the logistic teams. The logistic team has to ensure all these supplies are available so that the operations team could run the show. Now the next thing is triage. Triage is the process of sorting, basically the sorting of injured people into groups based on the severity of their conditions. So the whole purpose of, sorry. Sorry. The whole idea of triage is to ensure that the most serious person gets treated first. And for the purpose of simplifying the process of triage, it is generally color coded. The red color tag or red color coding is given to the patient who is critically ill and needs immediate attention. Delayed care or yellow coding is given to the patient who can really wait for a couple of hours, maybe up to 2 hours before deteriorating into a red patient. A walk-in wounded is generally called a green patient or a minor care patient, and black is generally called a dead patient. Black is labeled to a dead patient or a amputated limb, unidentified amputated limb. It's labeled as black. There's another category which we do not use in India, that is blue, who is critically ill, alive but non-salvageable. So in India, we follow these 4 categories: red, yellow, green, and black. For this purpose, we need to have a designated triage officer or a field officer or triage nurse who can actually perform this duty, and we have to train the staff on conducting the triage from time to time. We have to have a covered and earmarked area, preferably for conducting the triage protocol in a hospital. And a waiting area should not be preferably used for these purposes, as there is a lot of probability of spillage of the contaminated material or spreading of infectious diseases there. So an open area is preferred, but it should be covered. The triage area should be in close proximity with essential services like water, toilets, essential supplies, ICU, radiology department, etc. for ease of access. There should be a provision for easy patient identification. So as soon as the patient lands up into your site and is triaged by the triage officer, he should be given a number or a coding, unique coding, so that he can be identified and traced from place to place. From triage, he goes to emergency department, yellow area. From yellow area, he goes to say radiology for getting the X-ray done for a broken limb. From from the X-ray department, he's taken to OT for fixing of that, closed reduction or open reduction of the limb, of the fracture. From OT, he is brought back to the ward area or the inpatient department. So that unique identification which is given to that particular yellow patient in the triage area should be carried with him, should travel with him in all these areas of care, and he should be correctly identified as he was identified at the triage level. So this is the whole purpose of the triage. And the operationalization of the protocols of hospital admission, discharge, referral, and access to operation theater when the disaster plan is activated to facilitate patient flow is the key reason why we triage the patient. It does not get struck, the patient does not get struck because of identity crisis or a mixed identity with any of the co-patients. We have to have a robust triage mechanism and identification mechanism in place at the triage level itself. Surge capacity for medical response. The hospital capacity is this surge capacity is the ability of a healthcare service to expand beyond its normal capacity. If I have a 100-bedded hospital, generally 10% of my hospital beds can be called as my surge capacity. So the hospital, if we talk in the clinic, these terminologies, the hospital treatment capacity, HTC, is defined as a number of casualties that can be treated in the hospital in an hour, and is usually calculated as 3% of the total number of beds. This is hospital treatment capacity, and hospital surge capacity is a number of seriously ill patients that can be operated upon within a 12 hours period. So within 12 hours period, it is generally approximately 10% of the hospital beds. We can actually have provision for that much of those many numbers of beds, first of all, and a number of operations that we can carry out in the 12 hours time tells about our surgical surge capacity. How much patients can we operate? Because most of the injuries following an accidental disasters are of orthopedic nature. Then the thing is, we have to have a post-disaster recovery plan. Recovery plan generally talks about how am I going to come back to my normal functions after the disaster phase is over. So the first thing is I need to deactivate my disaster response and start my recovery activities. I have to, if I have stretched the elastic or the rubber band to a level and I leave it, the rubber band recoils and comes back to its normal shape. So that is my recovery activity. How am I going to do that? How am I going to achieve that? How am I going to resume my normal functions, operational functions of the hospital? In this phase, I need to conduct my post-disaster damage assessment, and post-disaster need assessment is also carried out in this phase. I need to study my time and resources that I'll be requiring in case if my facility is also affected by the disaster. If I have to reopen some area, I have to reconstruct or my facility, how much time and resources do I need to fix the internal damages? Then post-response report I have to make and submit to the authorities that this is the amount of damage, this is the number of patients that we catered, these many females, these many males, these many children, these many infants, these many deaths, these many amputated limbs, etc. And this count and this number of blood consumption, this number of surgeries done, these numbers of intensive care patients treated, these many numbers shifted outside or transferred outside, these many numbers treated inside in-house and discharged well. So all these statistics and the outcome of the disaster response has to be reported, well documented and reported. Lastly, we should not forget the staff who is there at the front foot and managing the show, because the disaster must have affected the staff also, their houses, their families, etc. So we should not forget to recognize the services that our staff has provided to the patient care. And we should also hold a debriefing session for the staff and should tell them about all these things, that we are going to come back to the normal operations. This is the amount of damage, this is the loss, this is the report, this is our outcome, this is our output, and we did well. How did we fared in the disaster preparedness, disaster response, sorry. All this need to be done in the debriefing session. Then coming to the patient handling part of it, patient handling actually, patients really we can divide into ambulatory patients or the outpatients that are coming to the hospital on a daily basis, and the admitted patients. We should have these statistics ready at us. From these patients, from the inpatients, we can further categorize the patients into the patients who are seriously ill and depending on a third person or another person for mobilization. What is that number and what is the severity of the illness? And the patients who are not seriously ill but still need help for mobilization, and patients who are not seriously ill and do not require any help for mobilization. So this kind of triaging of internal patients has to be done by the internal patient care department. This also is a relevant part of the HDMP or the hospital disaster management plan. This should be written in the plan that as soon as the disaster trigger is placed, disaster trigger is up, the inpatient department has to actually have these statistics in hand, that this is my critically ill patient, needs support for mobilization, critically ill, do not need support, critically ill, not so critically ill but need support. So these three categories they should have. Similarly, the other side of the patient side of the occupants of the hospital, which are attendants, the visitors, they should also not be ignored in our disaster management plan. They need to be made aware of the hazards and the risk that the hospital faces, and the emergency exit routes and evacuation plans. So many times the hospitals are required to put the flyers, the sensitization material in different languages, sign languages, pictorials, etc. at prominent locations, so that the patients, their visitors, their attendants are actually made aware of the kind of hazards that can occur in the hospital, and what are the emergency evacuation plans available with the hospital. So the whole idea of patient handling aspect in a disaster plan is to ensure no panic and chaos, because many times deaths do not happen because of the actual disaster which has stricken the organization, but the panic and chaos which arises after that while managing the crowd. Then volunteer management, involvement and management. I have already discussed volunteers are the part of are an important part of disaster management, and involving volunteers should not be ignored. They bring us a lot of information, help, blood, medicines, etc. And local level volunteers should be, we need to harbor them, we need to train them and make them a part of our pre-disaster plan, and we should have their key details like their contact numbers, their location, their strengths, their weaknesses, and we should conduct regular trainings for these volunteers in terms of the basic life support, the response, search and rescue, first aid, basic, all these things, triaging, because many times when our own staff is down or is unable to cater to the large influx of the affected patients, the volunteers actually come for help. And to make them more participatory, we should get them involved in the drills, mock drills, simulation exercises, tabletop exercises that we conduct in our hospital from time to time. That is another very important part of keeping the volunteers active and involved. This is another very important area, and last part of the procedural preparedness, wherein we have to have area level networking. The hospital shall make efforts to integrate the disaster plan with the district disaster plan, then with the state disaster plans and the national disaster plans, or the guidelines that are issued by the government from time to time. And their disaster plan should have relevant components which are aligned to various authorities. They should have repertoire of the nearest blood banks, nearest network hospitals, nearest mortuary, nearest ice vendor, because many times we need ice for storing the dead bodies. Mortuary is full, or storing the amputated limbs. So all these purposes, when the capacity of the hospital is overwhelmed, only the network comes to the help and rescue. Similarly, if I have to talk about, the coordination with wider disaster preparedness initiatives, so when you submit and prepare that report, you actually submit the report to these higher authorities for reimbursement of the losses. So a regular contact with the health sector, general disaster management preparedness bodies, etc., is important. From the HIRS or the hospital incident response system, the commander or the team committee head, they can do these activities at a regular basis. Lastly, there are some other collaterals which should not go ignored, which should not be ignored at any level. These include the maintenance and inspection to have the safe hospitals. Regular maintenance of occupational and functional components, which I think Pranav covered very nicely in his slides, is the key to have safe hospitals. The policies and plans have to be up and working. The structural systems should echo with the disaster plan. It should not be that I do not have a fire NOC and I'm talking about a disaster plan. I am talking about the protocols, etc. I do not have a fire display. I do not have a fire, this mechanism, identification mechanism, detection system, and I'm talking about the fire safety plan. So I need to have a structural system in place before I go ahead with the procedural part of the disaster management. And lastly, the most important is licensing and accreditation. This becomes the base of the pyramid when we talk about the disaster plan. If the licensing we all know is a mandatory requirement and accreditation is voluntary, and the standards laid down in the licensing body by the licensing bodies and accreditation bodies, if we follow those standards in letter and spirit, believe me, more than half of the problem of being devastated by any kind of disasters can be taken care of, because it talks very strictly about the building codes, about the implication, about the land usage, about the the floor heights, about the refuge area, about all these things, disaster safety at trainings, drills, all these things. If we follow the licensing and accreditation requirements which are applicable to my hospitals, because disaster management and health both are state subjects, so anything that is applicable to your state should be followed. If it is followed, I strongly believe that we can really make our hospitals safe without much of ado. So this is all from my side. Thanks a lot. Any questions, I'll be happy to answer.
Thank you so much, ma'am. You have discussed every detail of the disaster management plan or safety plan for a hospital, from starting from what is the DM and what are the database actual data, and then how the disaster framework came to India and how it grows. And in the last, what are the major components of a disaster management plan which should be implemented in a hospital? So I can see there is a lot of questions in the chat box, and there is a lot of discussions also going on. So I think I can put participants on unmute also, so they can ask by themselves. We'll try. Participants, you are unmute, so you can ask. If you want to ask anything, you can unmute yourself and you can ask. If anyone, okay, Jaspal Singh ji, you can unmute yourself and ask.
Role of the municipal corporation or the gram panchayats, we can say, on the local level, to ensure that there is proper hospitals maintained properly to face the disaster. And the second question is whether there is any census study done by the government agencies to ensure that these hospitals are disaster free. These are my two questions.
Okay. Ma'am? Or sir, anyone who can answer this question?
I'm taking this question, Pranav. Is it okay? Can I take this question, Pranav? Yeah. Jaspalji, thank you for the question. And as far as your first question about the roles and responsibility of the local government or the Gram Panchayat and the municipal corporation goes, Gram Panchayat is generally, or the representatives of Gram Panchayat are generally involved in the Rogi Kalyan Samiti, which is a important part of any healthcare organizations as per the National Quality Assurance System also. So they can actively participate in ensuring that the hospital or the healthcare facility which is there in that their particular area is capable of catering the disaster needs of that particular area, because the Gram Panchayat people are generally the one who are aware of both sides of the situation. Those they are aware of what disasters and the hazards that the community face in that particular hospital, and is my healthcare facility in my primary catchment area where I go for my basic treatment, is that capable to cater to that needs or not. So they can really voice their opinion in the Rogi Kalyan Samitis. Number one. Number two, municipal corporations. Municipal corporations are generally responsible for the licensing part of the healthcare facilities. So licensing authorities can actually put their foot down if they do not find the compliance up to the mark, adequate as per the standards laid down by the government. So these they can really play a great role, subject that they do not get into other side of the party and kind of becoming involved in other activities. So they have a really great role and they should play that. Number two, your question was, is there any census study for understanding whether particular health facility from a public health system, say a PHC or a sub-center to a medical college, a district hospital, is it disaster free or not? So as far as my knowledge, I don't know, Pranav may be able to tell, or Garima ji, or Dr. Garima, or maybe Dr. Chandra Ghosh may be able to tell. But as far as my knowledge goes, there is no such census study which says that this is the particular facility and it is disaster safe up to 70%. This particular facility is disaster safe 80%. So we do not have any such system in our census for health facilities as far as I know.
Yes, ma'am. There is no any grading or any kind of system in India currently for the any kind of buildings or in the healthcare system. But there is one framework which we can mention. It is National Patient Safety Implementation Framework, which is prepared by Ministry of Health and Family Welfare. Sir, you can look up to that. There are some guidelines and what are the procedures a hospital should follow for a patient safety. That is written there. It is a good document. Next is Baldev ji. You can unmute yourself and ask the question. Or anyone else want to ask anything, they can put in the chat box or they can raise his hand so I can unmute them. There is one question started in the chat box. Watch. Request guidelines as PG in disaster management after MBA, PhD in business management. I don't know what is the question. It's not written very correctly. And what are the role? What are the role? Whether is there any other question? Anyone? Okay, Neha. Yes, Neha, you can unmute and ask. Dr. Neha. Dr. Neha, you can unmute yourself now.
Yeah. Thank you for giving me this opportunity, Dr. Neha here. Is it some kind of a physical training about this is being provided by NIDM if somebody wants to organize some kind of a physical training in the setup?
Yes, we provide different kind of training and capacity. We organize different kind of training and capacity building programs related to the different disaster related matters. So if you send us any request or proposal, and it is also depend what at what level you want this training, because we try to implement these programs only on state and national levels only. For district level, you have different authorities to whom you can request, and also in your state there is STMA to whom you can write about the training.
Okay, because as such, I am into patient safety specialization, also into the hospital long time as anesthesiologist and working on those things. But I just felt after being the part of this wonderful webinar, we probably the kind of training as such every organization in the hospital is providing with the teams. If we get collaborated with NIDM team and go for a training, maybe we'll learn something much better.
Definitely, ma'am.
Physically, if we get that thing done.
For physical training, if you are talking about your particular hospital, I would request you to contact with your district disaster management officer, and
Okay.
he will provide you the things, or he will guide you for the necessary action. And maybe he can suggest you to write to the SDMAs also. So for particular hospital, I'm not sure ki NIDM can take any step on it, because we generally operate on national or state level, ma'am.
Okay. Okay.
Yeah.
Thank you.
Thank you, ma'am. District disaster management. What is this question, sir? Okay, they are discussing by themselves. So participants, if they have any question, any other question, anyone want to ask, or otherwise we can conclude this webinar today. So I don't think there is any question. I want to share something. NIDM has prepared a certificate of appreciation for our speakers, and it will be sent to both of you by email today or day after today. So thank you so much, both of you, for joining us and discussing this important topic and sharing your valuable thoughts and your findings with our participants. So I think Dr. Garima and Professor Ghosh is busy with some another meeting that is going on. So I would like to conclude this webinar, and I want to say that in starting, Professor Ghosh that says that practical application of new innovations and technology in new infrastructure development is very important to make it more robust and resilient. And after that, when Mr. Pranav discussed his presentation, he talks about the fire safety, what are the different methods and what are different causes a fire trigger in a hospital. And after that, he also talks about the earthquake, and then he discusses about different mitigation measures, simple tools and methods, how we can use and how we can mitigate a big disaster. And in the last, Dr. Nidhi taken the session on disaster management plan for hospital safety. And she started from data of disasters in globally or Asia. Then she discussed about the frameworks of disaster management in India and globally. And then she came on the disaster management plan or hospital safety plan, and she discussed each and every component of that plan, like how a safe hospital should be, and what are the hospital incident command system, what are the coordination and management, how what should be the information and communication system, how the safety and security should work. So in this way, she discussed a lot things. So thank you so much, ma'am and sir, for this webinar today, and I hope we will conduct more these kind of program for our participants. This is from all my side. Thank you so much to both of you and our participants also for attending this webinar. Thank you so much.
Thank you,
Welcome.
Shreyesh. And
And
hope
thank you,
to
Nidhi
have
ma'am.
you discussing more about disaster safety, especially for the healthcare sector, healthcare facilities. Thank you, Pranav. It was insightful listening to you, believe me.
Here, ma'am.
Thanks to Professor Chandan Ghosh and Dr. Garima for having me here.
Thank you.
Have a good day.
Okay, thank you.
Everyone.
I'm concluding it. Okay.
Thank you.